Morning. I am so excited that everyone is here. I'm going to introduce our first speaker, who is Dr. Jack Richman. So I want to give the proper introduction because, as Dr. Rothman mentioned, he's been in the business for 50 years and his bio is quite extensive, and we are so excited to have him as part of Eastern State's optometric. So Dr. Jack Richman has held appointments as a clinician and lecturer at 3 colleges of optometry in his areas of expertise. During his career, he has served as lecturer and chief of pediatric optometry and binocular vision service at the Pennsylvania College of Optometry, SALIS, the Michigan College of Optometry, the New England College of Optometry, and most recently as a part-time adjunct professor at the Massachusetts College of Pharmacy and Health Sciences School of Optometry. Now retired, Dr. Richman is a professor emeritus at the New England College of Optometry and continues to lecture both in this country and internationally. His principal areas of clinical and didactic work are binocular vision disorders, children's vision care assessments, vision attention dysfunction, eye movement and reading, and the effect of drug impairment on eye movements, pupils, and motor coordination. Dr. Richman has published over 65 original research studies, topical review articles, clinical test procedures, and book chapters on these and related topics. He is a fellow of the American Academy of Optometry, a diplomat in the section of a pediatric optometry, binocular vision and vision, a fellow of the College of Optometrists in Vision Development, and a member of the Neuro-Optometric Association. In addition to his career in optometry, Dr. Richman completed training and certification in law enforcement and has been active in this area for more than 25 years. He is a standardized field sobriety instructor and a certified drug recognition expert and instructor. He served as the medical consultant to the National Highway Safety Committee's Technical Advisory Panel of the International Associations of Chiefs of Police for over 16 years. Presently, Dr. Richman serves as the police physician for the Hingham Police Department in Massachusetts and is active in training prosecutors, toxicologists, physicians, and police officers in New England and throughout the country. So without further ado, welcome, Dr. Jack Richman. We are so happy to have you here. You're up, Dr. Richman.
Thank you. Thank you. This is an interesting exploration this morning, and it's going to cover, hopefully, a lot of the work that I've done for the past 30-some years, and it'll give you a different insight that may add to your approach to assessment and treatment of vision and learning problems, traumatic brain injuries, and other neurological problems. So with that, we'll get started. I'm going to share how I got into this in the introduction. And what I noticed years ago working in the schools was many children are reported of having inappropriate vision behavior that we often see, problems in so-called eye movement and control and eye tracking, and problems in accommodation and binocular vision. And then I realized working in the schools in Pennsylvania, I started to take pictures at the time and how I couldn't even concentrate in those rooms at the time. The distractions are still very prevalent when kids are in school, but it's also the interactions that are there. And what I noticed were kids who would just be sitting there and just not listening or doing anything. And I observed this off-task looking time. and it puzzled me that it may be a key to some of the things that we're seeing. So that is something that I now started to pursue. So over 50 years ago, when I graduated from the Pennsylvania College of Optometry in Philadelphia, I remember being taught a very basic concept. Accommodative or invergence anomalies may cause symptoms and may have diplopia, and this will reduce attention and reading tasks and increases distractibility. I actually dug up some of the old notes. Reducing or eliminating the visual condition now can lead to improvement in attentional status. So, yes.
Sorry, I'm going to pause because I want to let you know that you are not sharing your slides yet.
Oh, they're not?
No.
Okay. Where do I go back up to that? I thought I had them on.
No, you need to go to the share screen within Zoom.
Okay. Share screen. Now you see them. Here we go. How's that? Are they up?
They're coming. Yep, there you go. And then just hit slideshow, remember?
Slideshow. There we go. So we're back.
Yeah.
Fair enough. Can you see them now?
Excellent.
Okay, I apologize for that. Okay, so what I realized, you couldn't determine in problems in the classroom. It was very distracting. So what I started to look at was these kids, they were constantly not looking at their work. They were looking at other things all over. And I said, there has to be something there. So what I discovered, and when I looked at my notes, is that if there's a vision problem, it could be affecting attention. And the primary problem we thought was either an oculomotor, tracking, accommodative revergence causing the attention problem. But then I worked with a teacher in special education, and she basically said to me, was what we needed to do is pay attention to other things. She didn't like the model that I had proposed to her. So I said, okay, what would you like me to do? I saw a child in the office setting, and there were clearly ocular tracking and ocular motor dysfunctions, as we call them today. Accommodative tests revealed slow facility and other kinds of dysfunctions. And she also had a convergence insufficiency at the time. So the teacher said, okay, fine. Why don't you test her at her very safe desk that we have set up for her in her classroom? And I tested her now in the classroom. And what did I find? None of the things I saw in the office. And I go, oh my God, the symptoms and findings did not match. What am I missing? I couldn't figure it out. I had no idea why there was this inconsistency. And that was something that started with me when I was working in the schools in Bucks County, Pennsylvania, many years ago. So that started me on this. And it created a number of things that I had to consider. And I had this dilemma. So because it's like shooting at a target and you're not hitting the target. And why wasn't I? So the first thing I had to question in this dilemma is if a child exhibits an attention and an ocular motor problem, can they occur simultaneously? The other is the paradox that I've often run into, and many other people who work in vision therapy and dealing with children, is the teacher and the parents believe it's an attention and a distractibility problem, calling the kid having attention deficit disorder or not, but just having an attention and distractibility. The optometrist believes that it's an ocular motor and accommodator problem when they do the evaluation. So that's what I ran into. And I had to figure out, what is this link? What is the overlap of this particular thing? The situation in which both attention and an ocular motor and visual problem can occur simultaneously. And I had to figure out some ways and looking at how I can get a handle on which was which. And so the problem and the question that I had to deal with is, what is the primary problem? Is it an attentional problem that's affecting the testing, or is it a ocular motor accommodative invergence dysfunction that is the primary? And I had no way to figure this out years ago. And I started to explore what was known in the literature, trying other things, because I couldn't accept that I'm the only one seeing this, but I guess I was. So it was a classic catch-22. It's like, you can't get a job without experience, but if you have no experience, you can't get a job. So I had to get some experience in understanding what I was looking at. So I took another long look and reviewed on a quest, on a journey, what I was taught and practiced in functional vision testing and vision therapy. Now, this approach that I have used I've been using for quite a few years when I was in private practice and in the clinics, dealing with interns and inner city kids. And I had to find ways to separate it and get it much more efficient in the way I was treating them. And that's what I'm going to share with you today. And hopefully it'll give you some new insights. The issue is not whether attention is involved in the generation of smooth pursuit and eye movements. The smooth pursuit system uses visual attention when tracking a moving target of interest. Well, I read that a number of years ago. And also this author said, smooth pursuit eye tracking represents one of the few conditions in which attention can be engaged on a target for a prolonged period of time. I said, wow, that's pretty profound. Therefore, eye tracking responses can be used to study the dynamics of attention, either transient or sustained. And that was written 94 years ago in 1928 when I dug into this. So I went to an academy meeting and I said, I don't think there really is anything called a visual tracking problem. It's probably reflecting more of an underlying attentional problem. And so I continued to explore this and then trying to see how it related to eye movements in reading and then to several other functions that I've talked about over the years. So this is why we're going to go on this track. So my approach to this assessment and addressing this dilemma, and I'm going to share some of the things I saw. I gave you a pretty good list of references that you can explore this on your own, because it's hard to compress 40, 50 years of this exploration, but I'm going to try to make it succinct as I can. If the processing now of visual information efficiently and automatically, and this raises the question of what is automaticity, because that's something we tried to achieve in vision therapy. Then I would raise the following. First, is treatment for vision disorders and vision therapy without consideration of the role of impaired attention a limited viewpoint? What I'm saying is unless you can assess and understand what is the visual attention functions of this particular patient, be it a child or an adult, okay? And before you start any kind of vision therapy or any recommendation, you need to look at what is their visual attention status and their ability to handle sustained vigilance tasks. Second, if there are visual attention and automaticity problems present, could they influence the reliability and validity of clinical findings? Well, that was where I started out in my very beginning of this presentation, is that I was blown away by the special ed teacher that said, little boy, take your toys, come into the classroom, and because I know this little girl does not have the problems she said she had. And that's where I needed to, it affected the reliability and validity of my clinical findings. That doesn't mean that what we do today is wrong, but I think there's a more efficient way to look at it. Third, could improvement observed in vision therapy for ocular motor, accommodative revergence may possibly reflecting changes in visual attention and automaticity? This I raise as a very important point. When we look at what we do in ocular motor therapy, you are engaging the child. You're engaging them and giving them feedback. And therefore, you think you're changing, or maybe we're changing the ocular motor functions. And I would propose we're probably not. We're improving their on-task time and their ability to allocate attention accordingly. And the same with accommodative facility and anything, even with prism flippers or many of the other activities, what we're doing is increasing their attention on task if they will pay attention. So these are some of the things that we're going to explore, and I'm taking a different view of it. And fourth, if treatment is first directed toward an attention and automaticity dysfunction that you found in the beginning, when you did your assessment, then could the initial clinical dysfunction findings for the standard things, the ocular motor, accommodations, and vergence be normalized, and you didn't need to do anything that we classically do if you just improve some of the on-task time. So this is what led me on this quest to see how I can get more efficient and more effective in this. And the fifth factor is, I think there is probably something that is common to all of them. And when we looked at all these different things we talk about, visualization and visual memory, it's almost like the six blind men in the Sunni picture describing an elephant. And depending on which part of the elephant you're looking at, you think that's where the animal is. And what I was trying to figure out is maybe there is a common factor, and one of the, or two of these, was the visual attention functions of the individual and the automaticity, which then will lead to the primary thing that we see for school-age kids, which is reading and improvement in the classroom. I think it also relates to a number of the comments and things I've run into during our COVID isolation, is where the kids' ability to stay on task on a computer screen was greatly challenged. And I had numerous calls from various docs, especially some patients, regarding why are they going down when they were doing very well in the classroom. So we'll see this. So what we're doing in this journey is looking at eye movements and reading and visual attention. And are these things related? And I'm going to try to lay out what I found. And there is a link and a rotating thing between visual attention functions, which is not a unitary thing that has many components, eye movements and binocular vision reading efficiency, and automaticity, which is also visual efficient processing. And there are relationships. So back in 36 years ago, I did a study because I was fascinated by this. And we looked at the off-task looking time and off-task fixations during sustained visual attention tasks. And we then related it to teachers' observation checklists. And could this relate to the original dilemma of which comes first, attention or impulsivity, or what other reasons could be there? So we did this, and that paper is part of your list. And then if you want the full paper, I'd be glad to send it to you. Since we don't have the access, well, we still have access to the old journals. But this was called the use of sustained visual attention tasks to determine children at risk for learning. I was really surprised the way it came out. And we found that when we looked at the data, that the influence of this and other things I then published in 23 years ago about the influence of visual attention and automaticity in the diagnosis and treatment of clinical oculomotor accommodative convergence dysfunctions. And this was in the Journal of Optometric Vision Development, which was at that time under COVD. So this is a kind of direction I went. So I want to share a lot of the things that I learned about this and how you can apply them practically in a clinical setting. So I needed to explore some new questions. So I had to go back and look at eye movements and what I learned in school, but even later on. What happens when we visually search and scan for information? What is the relationship between fixations and saccades when we're looking and processing visual information? And I was absolutely fascinated that how much I did not know or never was really taught in school, or you had it in your first year of optometry school just to get through vision science. So what I found is it tells us something that's very important. The initial one is, where are we looking? Just watching where someone is looking is a very profound component of what we need to be aware of, okay? And I would just sit and watch the kids and or the individuals, even in the waiting room. I would watch what they're doing, what are they looking around, and it gave me an idea of, compared to other kids and other patients, what is it? Is there a pattern? So I want to see what they're looking at. So, and how efficiently are they gathering visual information? So I said, okay, maybe I'm not the first one to ask this question. So then I looked at data that came out on what are called scan tasks. When we look at a picture It was very interesting. We track where the fixations are. Where is the areas that people are trying to capture the most information in a short amount of time to come up with an answer regarding, in this case, facial recognition. And I picked that particularly because that's what the algorithms use for facial recognition. But we can just look at someone and watch the eyes, where they're looking, and it's an important thing. Today, unfortunately, it's a little challenged because everyone's looking at their phone, so you can't really tell what they're doing. So what is this relationship between fixations and saccades? Well, the first thing I learned about it is what does each fixation send up to the brain? It doesn't send a picture, it just sends chunks and information to be processed. And hopefully it's coming in smoothly. And if it's not, that can disrupt that information. And what does the chunk send up? Simply lines, angles, and curves. That's all it sends up to the cortex. And the brain then has to assess this and put it into recognizable matches. So what guides the eye from one fixation to the next? Well, one of the things is visual attention that is allocated to the periphery to determine the location for the next fixation. If they do not have an appropriate visual attention allocation in the periphery, some of us look at this as the magnocellular system and the parvo system, but this is where attention, and I'll show you some of the amazing literature and studies that have been done to link it, that it's a visual attention phenomena that is critical to this. So the location in turn is transmitted, and then our eyes move to the next spot. Here is an example of what we see when we're driving and how much is taking place every quarter of a second. Someone is driving, every one of these red spots is a fixational change and a chunk of information while you're driving a car. And there have been numerous studies to assess this. And this is what we find, that individuals who have various diseases, who are under the influence of drugs or alcohol, these fixations and the accessing of the information and sending them up are greatly disturbed to make decisions while you're driving in a vehicle. Well, the same thing takes place when you're going to a supermarket, when you're searching for things in other places. So I wanted to give you an idea of the complexity, but I think that we have the information and the techniques to capture this. This is one of the areas I've been working a great deal with in law enforcement, because we know that alcohol will disrupt significantly your fixation and vision processing, especially when it creates a nystagmus and an impaired pursuit. But that impaired pursuit is also related to visual attention. Another one that was fascinating was that of radiologists, and they've done a number of things with radiologists, and they looked at fixation scan pass of attending neurologists versus new residents. And there was a lesion in these x-rays, and they wanted to see what was their scan pass of the experienced individuals and the new ones. How much time did they have to spend? And time is another incredible, critical component for processing of attention. And measurement of time is critical when I do any kind of evaluations. And they found that they took longer, had many, many more fixations before they could come up with an answer and a diagnosis. Well, if I were to say, if I'm looking to see that pattern, I would almost look like it was a learning disabled kid, because these new residents were spending a lot of time before they came up with the right answer. So there's a learning curve, and what they gathered from that was a better way to give the locations, give the guidance on how do you look, how do you scan, where do you allocate your attention when you're doing these looking the radiology assessments. And I've talked to a number of radiologists, I've talked to many ER docs, and they find this absolutely fascinating because it helped explain why some of the residents who were working with them actually appeared to be learning disabled individuals. And that's what one had called me about, down from Johns Hopkins, who's a close colleague of mine. So I think there's a great analogy to this. When we look at famous paintings, where do we look in these paintings? Where do we learn about them? Here are the scan paths when we look at this, and where are the people focusing the bulk of their time to gather information on these. So there's a whole science out there of scan paths and where do they go. And that really fascinated me, because this is also attention. It also is the faster they can gather the most information in the least amount of time was important. Okay, here's some recent article that came out. Can autism be diagnosed using the eye trackers? And on one side, what you see, let me go back here, is on this side, this is the pattern of a autistic spectrum diagnosis disorder. And here is an individual that did not show any of those things. There's clearly differences in scan paths, and there are a number of places that have talked about using this as screenings on younger children, and there's quite a bit been published. But what's driving this is allocation of attention. It's just not the eye movement path. The attention seems to be disrupted, and how can that be changed with them? And a lot of the therapeutic techniques that I've been involved with in special ed programs and schools, I find that what they're really doing and the ones that get the best results are the ones that are changing the way the kids allocate their attention and where they're looking and giving appropriate feedback. Here's scan paths, okay? The one on the left, which one of these individuals compared to the right would be the scan paths of a, quote, perceptually impaired child versus the normal? If you notice the one on the right, it's quite clear that you see very few movements to decide they're then going to draw it correctly. The one on the left was the individual that had to spend a lot more time, a lot more chunks. So by capturing this information, I played with this 30 years ago to see how we can do it just with a video camera at the time. So the information is there. We just need to know how to look for it. So these programs and their reading and eye movements, these are important components. And that fixation we've often heard is called the what is it system, and that's the focus system. And then we have is the saccadic system is the where is it? And that is one that it depends a lot more on transient contrast sensitivity of where we're planning to make our next eye movement. In fact, the programming to make the next eye movement is almost fully decided halfway into the fixation that you're already doing. So that there's a whole match between these. And if these get disrupted, and these are with attention, then what happens? You start to see multiple regressions, and they don't get the information in efficiently. That is the role that attention is doing. An air traffic controller is one that has to have very, very good skills. The military has trained individuals with pilots with these kinds of faster information processing to increase their attentional allocation to various areas. We can learn from this. So with that, and that's a quick one, but there's articles I gave you in there that you can look at. So what are the components of basically of reading eye movements, and how are they going to be considered? Well, we have the 4 components. We've all seen those. And they involve the actual eye movement itself, the fixation, duration, how long does it take to go to the next one, how long are you staring at the one target, and some are very different. The regressions, where you now have to go back and relook at an original spot, be it in a picture or a task, or even on reading a line of print. Those regressions tell us a lot, but all of those are time-based. Because they're time-based, those are going to use up and give us clues. Is attention affecting this, or is there something else affecting this, or is it a combination of factors such as the visual attention of the individual, and they're developing the skills they needed for automaticity in a particular skill. So this is why I'm weaving these things together, because I find in a lot of cases that I've worked with over the years, people have had treatment for convergence insufficiencies, for intermittent strabismus, for accommodative dysfunctions, and the kid comes back into our office, and what they were saying is, well, we went to vision therapy, they did a little better. And what they never did or failed to do is get it to an automatic level. A lot of techniques need to be gone into at an automatic level. How many people do the prism jumps, but while they're reading, but while there's distractions and while they're being timed? So you want to get whatever improvement you get, you want to get it to an automatic level where the child does not have to think about bringing the eyes together or getting a clear focus. So I think these are important pieces that I'm stressing when I talk about automaticity, visual attention, and the eye movement readings. So let's look at this a little more. And I think you're all familiar with this, that we know that these facts that exist about when we look at a fixation, a regression, a duration of fixation. And one of the interesting things here is the longer these lines are, the more time it's taking to process. And what we'll see is it's like almost reading a foreign language. And how many regressions are taking place? Are there different times of the day? Is there different other components that will have an impact? So when we look at, and how many of you still use a visograph or ever used a visograph to look at these patterns? Now, there are other devices out there. Right eye can capture some of this. This is what I particularly like. But years ago, even before I had this, I just used a video camera. And I used one of the earliest visographs. So you actually had to develop a black and white film to get these tracings. So here's what it would look like when we see reading the same material, someone who has a great deal of difficulty. And my point I'm making here, it's the time to process the information. And I want to know what is the potential role of visual attention to these tasks, if that's what's interfering, the potential distractors, and what is the automaticity in knowing the material. And I found this to be very common in individuals who have English as a second language and their ability to read. So these are typical recordings of that, and it takes longer to process. That's why we wind up seeing patients for vision therapy. It's taking longer to process. They can't get it done. And here's just another in actual tracking and patterns. More time to process. And I keep stressing the role of time in any diagnostic and therapeutic protocols that I was using over the years. So what is the relationship between fixation skates and how the letters and words visually perceive? I found this interesting and fascinating. It was written by Tinker and others years ago. Whole books have written, okay? What does each fixation send up? And we said the chunks and and lines and curves. But where do they get this? Okay, the chunk, that's the top part of the words. This is the part that carries the fragments. And I'll give you an example. If we try to read this, we don't have the top parts. If you try to read that to yourself, you're going to make a lot more regressions because it's the top part of the word and the letters and the space between them that carries the information that becomes automatic and you're able to process. Here's the reverse. Here's where you see it on the top, and that's a lot easier to read without the bottom. So this has been studied years ago, but carries a lot of information that we don't pay attention to. And that's the typography and shape of words and the materials on it. And this is something that I worked with for quite a while to see how we can get better results with individuals and find out how they can perform. Here's the top half that carries it, here's the bottom. And you can do this on any particular one and ask someone to try it and show it to them. And you see, and here's actually what it says. But when you're scanning across, it's the top pieces that seem to carry the most information, which then says maybe there's things that are perturbing this or upsetting this, such as accommodative problems, convergence problems, etc. So once we pick up this fragment and this chunk, it doesn't become valuable to us for reading until we match it. We're taking the top half of it, and we have to match it to the actual sound of the spoken word. So language will develop before we actually do the reading. So what you're saying to an individual, you have to understand the language, but now we're going to give you chunks of information that are going to match a specific sound. Those then become automatic. And there's a whole area within reading treatment, which is called fluency, which is an important component of this, and understanding it from an optometric frame of reference if we're going to get them to get the change in the classroom. And I'll address this in a bit. But taking this pattern of understanding how we do this, and it understands or says it's the word and. So anything we do, we look at something, and the classic example that I can always remember is the beginning presbyope, where things go in and out and fuzzy. And they said, God, I'm rereading things, it's taking longer because something is disturbing, something that was nice and stable, but it's not an attention problem. It's an ongoing either lenticular change, pathology, or very simply presbyopia. And you put them on the plus lenses and you put it back into a normal pattern. So it's understanding of this, because they also will tell me in the beginning, the amount of energy they're putting into trying to read and trying to keep it clear so that these fragments do not get disturbed. And with the onset of the computers, it's been a greater challenge. So if it gets disrupted, we get incorrect language fragments, regressive eye movements take place, we lose a lot of time, and the whole thing becomes inefficient. So what I'm trying to stress is we need to sometimes look at the topography. What are all the things that we put in someone to read? Oh, they look like they read okay. No, you need to look at it. I'm very careful, and I'm going to show you some of the ways that we can address these. Come on. Okay. So when we're beginning to read, we see about 30% regressions because we're learning to do it. It's like asking a new optometry student to find where the nerve head is, and it'll take them a lot longer than a fourth-year student or an experienced clinician, because they've learned to take what they're seeing and matching it very quickly. They develop these automatic skills of where to look and where the attention is. And reading, for what it's worth, is a guessing game of matching the fragments as fast as possible. Automaticity of word recognition is so important, and everyone does it in a different way, but at least we can set up ways that we can see this and getting it to a higher level if we're going to do the therapy. And I used to see a lot of kids in our city, they didn't have the time. I worked on these activities within 1 or 2 weeks, and we got very nice differences in the kids' reading skills because we'd already gotten and addressed the attention problem. We've already addressed the accommodative and the divergence functions. Now we had to get it to an automatic level. So hence the title of what I'm trying to present is automaticity, visual attention, and how does it relate to the reading and eye movements. So how do our eye movements control during reading? Well, one of the major ones that's a very profound one is called the easy reader, and I gave you a reference to it. But what it does, it simply says, we look for low spatial information in the periphery. That's the magno system. And that's going to initiate a saccadic program. And then the high spatial frequency is shifting attention, and that's the parvo. And they have to work together. And it was a very good, this is probably one of the better articles that I referenced for you. In the cortical localization of these vergence and ocular motor learning that was revealed through functional MRIs. And I really, it gave a really good way to perceive how complex this is, but why it's important. So they compared neural activities. And what we have is all these different areas that are involved in accomplishing a single visual task to identify something and say or look at something, all different parts. And what I found was very, very profound. So I put it into a map, and others have done this too. So we see a target, and we go to the occipital cortex. But now, what does it have to do? It now moves on to other areas. Attention processing is in the parietal lobes and complex visual stimuli. Visual spatial attention and eye movement planning is in the frontal parietal lobes. It then sends it down to the ocular motor control areas. And the role of the cerebellum is a very critical piece too. Cerebellum has been related to dyslexia, whatever you want to call it, but also it affects motor programming, and it affects the spatial maps that are taking place. And I go, wow, when I looked at this, I said, this is dealing with eye movements and control, but what precedes all of that is very rapid attention processing and eye movement planning. And I want to see what's going on there. And this accuracy involves the entire part of the brain. And what is this relationship? And when we look at this, well, what are the clues that are in the periphery that guide eye movements? And what is peripheral vision guidance? You know, and that came out in a number of these studies. What out there where we're looking at something that we're going to decide where we're going to move to the next one? And there's so many vision therapy tracking books, activities, we're setting this up. But I wanted to learn more about it as it relates to reading. So what I found was some really fascinating things. The length of the sentences and shapes of the words and the fragments have to become automatic for recognition and comprehension. I'm going to stress this over and over. If that is disrupted or manipulated, they're going to affect the automatic and the attentional components for word phrase recognition. And what I saw this past 2 years, the kids never got the opportunities to practice in these areas, because I started to do some work with homeschooled kids. And they invited me down, and one of the glaring things they said is, well, they seem to can read out loud, but they just don't get it to a high automatic recognition level. So I looked at their attention skills. Some of these kids, some of them had significant ability to sustain attention on what their task was, and others were never given the opportunity in any kind of therapy, be it reading or classroom or whatever we're doing, to get it to an automatic level. So I wanted to see, what is this system? Well, this became even more interesting a number of years ago. The word length, okay? Space between words, first letters of words, and the comprehension. Spaces between words is very significant in guiding the eye movement during reading. We use these clues because we can't see the total words in the periphery, but we get this little gestalt of what we think is that word out in the periphery, where we're going to look at next. And we get a contextual clues, and we're going to see these very quickly. So we use global peripheral clues to guide our eye movements. And if any of these get disturbed or dysfunctional, we're not going to get past word-to-word reading level. And this becomes very slow and inefficient. And this has been reported multiple times within the reading literature, within eye movement literature, and the perceptual processes. So I took it to this level. And there's a gentleman named Dennis Fisher that did a great deal of work. What happens when we try to read? You try to read this out loud if you're looking at the screen. Try to read it as fast as you can. And you can't, because the spacing is gone. So you have to go back. And if I would do an eye movement recording, you'd see tremendous number of regressions, and you're trying to figure this out. And I picked a relatively easy one. So this space became an important thing, not only for therapeutic reasons with brain injured and other patients that I dealt with, but also for the kids as a way to see where the problems could be occurring. Here's what it looks like normally. Here is when space is gone. And I said, okay, let me understand something else what's done. If you look at most newspapers and materials today, they're redacted down to a 6th to 8th grade reading level, and they're in very short paragraphs. So there's much fewer pieces of information that you have to get in a line and before you make your next fixation. Now, if you try to do this in another book where it's print's very small, we'll have a difference. So let's look at some of this. We make the print smaller. This puts a greater demand on the recognition of the peripheral guidance system for making the next fixation. Many times there's head-eye movements, which is acceptable. But what we need to get an idea is what we put in front of the kids. So I've looked at a lot of college level kids, high school kids that were doing fine up to 4th and 5th grade. And now they're having a lot of difficulty in reading comprehension. And you do an ocular motor eval, and you do other assessments of accommodative and convergence. You'll find that there's some disruptions there. And these become an important thing is what is the print? So what I wanted to do is find out what can I do to the print to give them a normal reading experience? Instead of saying, oh, you can't read this, you're having trouble, let's see what we can do. So what I did is looking at what we know about different people and different tasks. And there are several strategies that you can pick up. Some people really do not like to read technical material. They like to read novels and fiction. Good. There's a whole different processing that takes place. And I've surveyed optometry students for many years who are very good at reading novels, and they can finish a book in a day. But then giving them technical articles to read out of journals, they have a terrible problem because they've not developed an appropriate strategy because the print is different. The way it's written is different. So I think these are important as it reflects on eye movements, okay? A painter and architect uses different fields. So the way we see is not determined by what we want to see, but how we've learned to practice seeing. It's a very profound statement, and I think it's important. How have we learned to see effectively as we get older into middle school and high school and college? There are several strategies that we can pick depending on which we've learned to see, and can we switch between them as a task change? That's a great challenge. I don't know if I've worked with dental students, students who were in law school have tremendous problems and have failed out because they could not manage the type of materials. And it wasn't because there was a visual problem, but they started to suffer in their attention and their work. So I said, let's try some things. Reduce the column width, reduce the words per line, increase spacing. So here's one of the things. If you have to read down from top to bottom, it's a lot easier because you don't need as much demand on the peripheral search guidance system. If I add more space between them, okay? Or if I just do what's called rapid serial visual presentation, where the words just flash up there, they found that teaching CIA agents could go at 4 times their normal reading rate to review and read material. So I tried this and this was the basis of the study that I did 30 some years ago when we try to look at the role for the basis of the DEM test. And that was the basis that we found that horizontal and developed the horizontal versus vertical ratio with the intent of getting some clues that if we remove that demand on the peripheral search guidance system, how fast can they do that? And this is what developed the concept of the ratio for the horizontal to the vertical, giving us a clue that there's something disrupted possibly in the peripheral search guidance system. And especially after, I can remove the factors of attention and other components. So I wanted to share that, and it's a kind of indirect way, and we'll come back to that. But if you can change the print size, change the spacing between that. I worked for many years in a traumatic brain injury unit in a hospital, and some of the patients, all they want to do is be able to read their Bible. They wanted to read some news. They couldn't do it in the regular format. And one device I found extremely helpful was a Kindle. I know, because I was able to shift that. And you can do this clinically. Take them and say, here's what you're having trouble reading. Let's see if you can at least get that if I remove that, the absence of the peripheral guidance system. Can you now process it? Now, I was absolutely amazed at how much more effectively, then you can add it back in. So you can make it all vertical, and then you can start to make it wider and having space, so you'll have less dependence on that. That's where I find that these clues, when I went on this journey about eye movements and reading and automaticity, became very profound because I didn't realize so much of this information was out there. And that's where I came up with the concept for the developmental eye movement test, and we'll spend some more time on that. So let's look at briefly what is visual attention. There's a chapter that I wrote on that in Learning Disabilities book for Scheinman, and I think I forget else who was involved with this, but I did a whole chapter that will give you a lot more information. But what is attention? Okay, it allows us to have more important information that we can filter. And filtering is an important component because that's one of the major components where attention deficit disorder kids, which now there seems to be genetic components, they can't filter. Their attention system is not filtering all the information, or it's overloading. So we want to be able to look at that. And there are several ways. What does it do? Well, we're searching for information that's necessary for a specific performance. I'm looking for a sign on the interstate. I'm looking for a product in the closet to do some cooking. I'll ask my wife, where is it? She goes, it's in the stuff closet. Well, what's that mean? It's up there somewhere. And it takes me a lot of time to find it. But so I have to allocate attention, sustained attention. It implies an evaluation. That's what attention is. It reflects a relationship between a process and a task to guide and support an act. So I look at visual attention skills. What is it trying to achieve? Can it be done? And if it's taking too long, then I potentially have an attention problem. Okay. To be attending, they must be set to do something, have to be motivated to perform a task to achieve some end, as it was with that little girl when I first learned that the environment was very important. And good attention refers to perception that messes with good performance by efficiently picking up the information that has utility. So the more you practice, and that's one of the things, the more you practice getting the feedback of good performance from good attention, then the information processing increases significantly. And that leads to the concept of automaticity. So is it a single process? No, it has many pieces. And these are the 7 basic components of attention when you look at all the literature out there. One is, arousal and activation. What is it? Or what's to be done is the initial thing, and you scan very quickly. Attentional gaze can be drawn to a particular location. I use the example of rubbernecking when there's a crash on the other side of the highway, and you're looking to see it, and your attentional gaze is heavily over there. Go, what is that? What's going on? And then you hit the rear of the car in front of you. So arousal and activation is a very powerful thing to get you engaged initially. Sustained attention and vigilance is one of my major ones, because that's going to be an important one, because you're going to have to detect infrequently occurring events. Air traffic controllers need to do that. When you're driving, you're watching for this. When you're reading and you're trying to search for certain words and pieces of information, they're involved. And this involves at least 5 to 10 minutes or longer time in those particular activities. Events are embedded into the background. And the key to sustain attention and performance is practicing it over time and doing it all the time to make it faster, making more automatic. And one of the ways that we tested this is what's called continuous performance tests. And here where a child is asked to look for simply a P, but all these different letters come up. The original studies used an AX, and they used different variations of that. And they had to, every time they saw a particular target that was one they had to look for, they had to press a key. Well, there were a number of things that were done for this, and that was part of my original studies that led to finding out. And so I used this, the use of sustained visual attention to determine children at risk, as I said, and that was an important component because what we did is we measured actually off-task looking time and the number of off-task fixations, and then related it to the classroom's observations. And what we found, the higher the time that they were off the task looking at that screen that you saw over here, and their eyes were wandering all over it, that gave us a very good clue that there's an attentional problem. And the purpose was to compare these kids. And we found that these did highly relate to the classroom teacher's observations. And we did it in 6 different schools. And it was able to really give us insights to what is the role of attention and sustained attention that may be affecting the kids' learning. And that was a long time ago. So the approach for this and identifying at-risk kids can also be valuable. Effort is something that's important that when we come to it. Effort is allocated to a task. The more you really have to allocate attention to a task, it's going to change their information processing capacity. When you're thinking or reading or being involved, you have a 30% increase in blood to the cortex, okay? You're having to put so much effort into it. And you say, God, I'm really tired. This was a lot harder. Other people are able to do the task very quickly. So how much effort is allocated to a task will affect the attentional component. So, and this is the processing. Believe me, I'm very well aware of that because I have lost a good deal of that ability following my traumatic brain injury, and I'll reflect on that later this morning or early this afternoon. So when you feel you have to actually be voluntarily concentrating, it says, one, I'm not at an automatic level. And I'll ask the kids, do you feel you really have to concentrate very hard? Well, yeah. And well, do you get tired? Yeah, I don't like doing this. I don't want to do this. Well, what do you find it's easier to do? I like to play basketball. Did you practice a lot shooting the ball into the basket? Yes. Well, did you have trouble in the beginning? Yeah, but I concentrated and it got a lot easier. Hence the concept of effort as it relates to attention is critical. And when you're in a vision therapy program or a vision therapy room, I'm going to be looking for the effect and how much effort is going into this. And we really have to pursue that because that's going to be interfering or also a measure of how automatic you're going to make these skills for that person. So the less effort, the more efficient and automatic is the central processing. And that's part of one of the factors in attention function. For an inexperienced driver, they can have so much activity involved just for their total attentional capacity. Nothing scares me more than seeing a mother with 5 kids in a van and she's constantly turning around. That unless she's really good at it, which many are, that's a recipe for disaster. Okay, and we get into this and this total attention with elderly or individuals that have suffered a mild stroke or have had some other kinds of difficulty, a concussion and traumatic brain injury. The effort component is one that I feel is so important that relates to eventually getting improvement in the skills and taking another look at how you measure this and asking them and talk about it. So time is an important thing, but also their feeling with it, okay? Driving with a phone is another component. Experienced drivers, it's basically a voluntary conscious effort versus automatic processing. And that is part of attention. If your attention has less effort to put into it, becomes more automatic, the process is going to be more efficient. And that's where I think sometimes in vision therapy, we stop too soon in the treatment of the patient because we're not attending to these components of attention, okay? It's like a computer running slow and too many programs running at once. Alertness is a component. Get ready, how to respond. Selectivity, the act of scanning, and which are the most important things. I do a lot of verbalization with the patient. I want them to tell me what you're looking at. What are you looking for? I want to hear them verbalize it. And if they can't do it, I'm going to slow down until they can, because I have to focus on their attention of what they're looking at. And then, of course, central processing capacity. It has limited resources. We need to be able to spend time and have a reasonable sized brain. And all of us know that central processing capacity will change as a function of time and task. When you have 2 or more events that require processing, and you may not be aware or actively involved when the response is automatic. But when you have to start switching between tasks and putting more conscious effort into it, this is where that central processing capacity is going to be more limited. And I'll watch this with adult patients I worked with and what they needed to do, because in a controlled environment, it's hard to do, but I take them out into the occupational physical therapy rooms at the hospital, and they would get overwhelmed, and the therapist would say, what's going on? And I explain what's going on. So we limit it, we get certain things automatic, and then we gently titrate it up. And I think this is why this is an important factor when we talk about central processing. And we want to restrict the number of attention demanding elements the mind can handle at the same time so that they now stay automatic, and then you can gradually improve it. And sometimes you can't, and sometimes you can't improve it after that point. And that's what makes some of these patients want to not continue in treatment, don't understand it. A therapist gets frustrated, other people get frustrated with it. But I'm trying to give you a model that makes sense, that I've found that makes a lot of sense to me when I look at a patient. I want to find where they can do it successfully. So the role of cognitive fields is also, and we know that the more effort you put into it, you're going to have what are considered restricted cognitive functional visual fields of how much you can deal with. And they'll say, I didn't see it. I missed it. I'm just overwhelmed. And that's for people driving, say, in traffic in Boston that never did it before. They just miss stuff. So we see a reduction because the brain's actually reducing their visual fields for processing, but they're functional fields, not a real visual fields. And there are some methods that can be used for assessing these. And one of them is called the useful field of view. It's been a test that's been available for many years, and it's highly predictive for individuals in driving where they're going to be at risk for driving. It's called it's useful field of view, UFOV, if you want to look that up. And I've used that quite often in the hospital and in the clinical setting. Okay, so these are components that are part of attention functions, not just staying on the task. And we get the inattentional blindness that occurs with this, where you actually don't see something, okay? And and they looked at it with eye movements. They scan for something that was previously an experienced pattern, but they don't pick up on it. And that's what's considered inattentional blindness. So when I spent a lot of time reading what other people have seen that is outside of optometry in this area, I was absolutely delighted. It was like a giant smorgasbord of making sense of what I was seeing clinically. Okay, so visual attention and ocular motor control. We're going to go, I said, for about 45 minutes, and then we'll take a 10-minute break. Now, visual attention and ocular motor control. Can attention functioning be revealed in eye movement behaviors? Yes, okay? And here's something that fascinated me about eye movements and visual attention. And this comes out of the articles that I gave you on your list. Visual attention, the where, what, how, current opinions, and this was written in 2003, another in 2002. Visual and cognitive control of attention and smooth pursuit. When I saw these headings, I go, wow, I never heard of half of this stuff, but now it relates to me clinically over the years. So what I found and what they said, the entire process of smooth pursuit requires visual attention. The initiation and maintenance of smooth pursuit is under sustained visual cognitive attentional control. In other words, if I'm asking someone to just look at a target and try to identify something, keep their eye on the target, that is attention control, and it does relate to smooth pursuit and the ability to stay on a target. Because a smooth pursuit is your ability to hold your eye steady on a moving target. And a lot of people cannot do that, and kids as well. When I see that, that's an attentional problem, not a pursuit problem. And the data is so strong to support that. So the controls of visual attention support smooth pursuit so that the eye tracking of a moving target can be prompt and accurate. These are not my words. These are words that others have written and well documented, okay? Here's some others. Attention and eye movements tightly interplay, okay? In fact, the second one is very profound. It is almost impossible to separate the neural pathways for visual attention from those of the ocular motor control, which means that what we're measuring when we're looking at pursuits and fixations is heavily linked to the attentional processes and those pathways. And if we can look at that as a way to evaluate whether there's an attention problem or whether there is something else going on, I think that becomes a very important component. So these are some of the articles I gave you references. If you cannot get them, you can email me and I will get them for you. It's one of the advantages of still being affiliated with 2 universities. And I find it's very effective because some of these are older articles and the librarian says, well, it may be a little hard. I said, well, if you can't find it, let me know, I'll try. No. And then, the librarian say, you've thrown down the gauntlet, I will get it to you in an hour. I go, wow, that's pretty good, and they do. So this stuff's out there. It's clearly out there. And when every one of these articles and the motivation to write them and all the references really swings me back to the role of attention, sustained attention, and automaticity as being the underlying for remediation and for assessment of these patients. And this is what I enjoyed doing for many years. I don't do it as much as I used to. I unfortunately only deal with people who are under the influence of alcohol and drugs now, but they suffer the same problems. So if there's such a relationship between attention functioning evident in eye movements, is there evidence that breakdowns in this are apparent in eye movements? Well, there's a lot there. Here, the brain and the circuits and the control play multiple roles. And what they said is that this work will show networks that control eye movements, but may be a source of attention filtering. In other words, if the attention system isn't filtering appropriately, it's going to affect the eye movements. And these neural circuits that control eye movements acted like a volume control and an amplifier to attention controls. And one of the interesting things that came out of this, and reading of this for quite a while, is noise and conversation. Someone can attend, and how many of you have turned down the volume on your radios? You're getting close to a spot where you got to turn off the highway because auditory seems to override these attentional components, and you can't do both at the same time. this is a very common phenomenon. So what I've done in treatment and what the OTs, well, the PTs have done is we start to now add in noise and discussions, okay? And what are these roles? And to see if whatever performance they've been doing, can they maintain it with these additional distractions? I'm involved in an assessment program for people at the rehab hospital for driving assessment when people have potential dementia, people with Parkinson's, and others with traumatic brain injuries or concussions. And we look at a lot of these functions and we use the useful field of view, we use it, and it takes time, but we get a lot more information and then take them out on the road and then make the comparison. So I'm bringing years of experience to it, but trying to give you some ideas where these things, so it's the loading of these distractors on top of somebody that was good and was able to process it and allocate the attention. And now I want to know where they break down and where's the area where it's good. And these are important. We see this with attention deficit and hyperactive dysfunction. They make a lot more intrusive saccades during fixation, and we've been seeing more of this. In fact, it's now considered a genetic cause for ADHD in many individuals. And they have the reduced ability to suppress unwanted saccades and control their fixation. In fact, there's another schizophrenics and bipolars have significant problems in pursuit function. And the reason that they're getting this, it seems to be related heavily to attention areas of the cortex that are significantly affecting the pursuit functions. And they use this as for a screening test for a number of years. And there's a good deal of information written on that. So we see that these things constantly overlap. And that we know this with many of these kids. Do I think that with kids with attention deficit disorders, many of them can respond to the therapy without medication, and there's others that respond with small amounts of the medications that will also improve it quite a bit as well, in addition to the therapy. So I'm always looking for and I'll get into the techniques of how I assess this shortly. Here is another example. Visual behavior of ADHD kids during an attention task, an almost forgotten variable. That caught my eye, and that was 22 years ago that people were writing about this. And they examined whether looking away behavior interferes with their test performance. And they found it did, okay? And when stimuli are unpredictable, looking away significantly interfered with the kids' task accuracy. That was written 22 years ago. So these were the things that I discovered that acted as a basis for my model that has shifted from the classical model that I was taught in school, and I hear at many lectures and things. Do I do a great deal of perceptual testing? No. Okay. I want to look at all these factors that come into play, because I feel from many of the studies that I've read and also my experience is that many kids who have, quote, perceptual problems, they also have the underlying oculomotor and attention problems first. And if I can sort that out and see that's what's there, I'm going to work on that, and then I'll go back to the perceptual, because many of these kids can't stay on the task. Okay, so these are important components. And then I looked at what happens when we do therapy with them. So it's a combination. Okay. There's an interdependence between brain systems controlling visual attention and oculomotor behavior. So I got to the point, there's no way to separate it. The oculomotor behavior was reflecting what was being processed in the attentional systems and pathways and the cognitive loads. All these were important to me because I'm seeing them reflected in the oculomotor behavior. Initially, they can be very good. I increase the cognitive load and the capacity, and then I see the ocular tracking and the ocular skills break down. Therefore, to me, that's a visual attention dysfunction and not an oculomotor. It's a way, it's a barometer of what's happening. It's my thermometer of what's happening with the individuals. And this study finds support the notion that deficits in inhibitory mechanisms might underlie the inattention characteristics of ADHD. So by embedding myself in this, and I'm trying to share some of these things that I've seen for quite a while. Okay, is that plenty of information for a while? I think that's a pretty good type of thing. And it's essentially saying there is no corner of the brain that is not concerned with the control of attention and eye movements. And so can disturbed eye movements provide useful diagnostic clues to attention disorders? And the answer is yes. Okay, so I'm going to start into this because we're going to take a break in a little bit. And what I think we'll do is, this is how I approach it in my practice and what I've done for years. And yes, I will do that. Actually, yeah, okay, let's do this. Okay, first thing I do is I'm going to profile every patient I can. I use the OEP checklist, I use other checklists, but I do a magnitude estimation method, which means it's 0 where it's not noticed at all, or it's noticed seldom, occasionally, frequently, and almost always. That's a general one, but I found with parents and patients, these was quite helpful. And so here's an example. Under that one section which says eye movement abilities, ocular motility in the classic checklist. And they would then put a score. And it also, you were able to get a lot more information by having further dialogue. So here is a pre-treatment where we find that head turns as you read the line of print, frequently observed, confuses left-right directions frequently. And so I get a score of 29. So what am I going to start to do now is look at the aspects of how I'm going to plan and evaluate, because it gives me a profile. And actually, after therapy, I go back to that same one, have it be evaluated either by the patient or their parent, and it's weeks later, and to see if I get changes in these that I can quantify. So I did these on hundreds of kids in the clinics, and I found that it gave me the way to adjust the treatment, to be right on spot with it, communicated with the classroom teacher, because the classroom teacher had noticed similar things, so I was able to have that process. And the way I would do this, we have lots of different ways. And chair-side observational techniques we've all used. The concept of off-task looking time is something that I'm trying to stress for you to understand, and off-task fixations. And attentional dysfunction, and it indicates attentional dysfunction, then difficulty with oculomotor control. So when we do activities, my first thing is position maintenance. Position maintenance is probably the single most sensitive function of the oculomotor and attention system. Can you hold steady on a target? I just put up a target, and I'm going to say, I want you to keep your eyes on this target. It may seem boring, but I'm going to time you. Okay. I go, usually when I was doing this, I would do at least a minute and sometimes longer. And during that period of time, I'm going to be watching, without moving the target, okay, how many times they looked off. Now, if I wanted to, I could also take video recordings, but I also did this in other ways with a visograph. And I wanted to see how long they can stay on that target and how much time they went off. So if I found that of that 60 seconds, that I had 15% of the time or more where they were looking off the target and had to come back, or I had during that 60 seconds, at least 5 to 10 fixations off of it, I got a pretty good clue in the very beginning that this was an individual that could not mobilize that fixational ability that is required for attention control. Right before I even move the target, even before I move it. Then you can do the pursuits. And you can do them in all different ways that we do. You can do physiological H's. And again, watching for those. But the unique thing that I'll do afterwards, if I go in this manner across and I find that they're off, I don't stop at that point. I've recorded what I needed. Use of the camera and video camera can be extremely valuable. But then I will repeat these. And I say, okay, I want to find a way, and I'd probably say this later on in the therapy, but I want to find a way of and see if I can improve it. And one simplest one is the use of the finger. I would do several different things. Can you follow this target with your finger? And I'm going to go slower. And I want to see now with their finger pointing to the target. And they keep putting their finger on the ball. I said, okay, we're going to do that first. Put your finger on the ball. Don't move your head. And I want to see if it improves. And what I've done is I've engaged the intention that's necessary. And if I find that now with engagement of attention, what happens? Does it improve? And in many cases it did. Now I said, now take your finger away, hold it just pointing to it. And I want to see if you can stay on this. And we're going to go for a whole 2 minutes. And they go, oh, that's a long time, Dr. Jack. I know. I said, I want to see how well you can do this. And then, but what it's doing is it's now stimulating that whole allocation of effort. Put all your effort into this because I want to see if your attention improves with the effort. Because now if I can get that, it can give me the kind of clues that I need for starting my therapy. I want to get them to a point as soon as I do my evaluation is to see where am I going to start my treatment. So it's a combined diagnostic as well as a one of treatment. And the more I have to reduce it down in terms of the speed and the activities that are involved, then that means it's going to be a little longer and giving, but it gives me the feedback techniques that are going to be essential if we're going to get improvement. So the other thing I found, and that's what many students will do, is they're going to do this without a question. They do the physiological H. It takes approximately 6 to 8 seconds, and they bless the patient. And I said, what did you find? Oh, they could track it and follow it. Well, what about their attention? Well, it looked okay. In 8 seconds, that's not enough of a sampling. So that's why I go longer, and I want to see if it breaks down. What do I need to improve it? Now, what I found that I needed a need for a standardized tracking target. So I just made this using PowerPoint, and it goes back and forth on the screen, and I can clearly determine the speed. And this is a real good use of some old computer laptops or monitors, and you're able to use them. And then I put the goggles on. And I wanted to see during usually I'd go for anywhere from 3 to 4 minutes, how well do they stay on the target? And I'm getting a recording at the same time. And here's what we get. I'm getting a nice sinusoidal movement. And if there's going to be off fixations, I'm going to be able to quantify them and see them for the period of time. Sometimes I go longer. And then if I can see this, but it's a way to quantify off-task fixations and how much time they were off. So if we go the other way is ask them to stay on this target, keep following it, keep following it. And then when I get the visograph, I see quite a few off fixations, and I can time them and quantify them during the evaluation. So I have a baseline before I'm going to start any visual attention activities of staying on task and working with that. And here's where I can quantify the number. So it works. It's a very inexpensive. Right now, the Visograph is harder to, the older ones are harder to come by. I know that there's some companies that are looking to bring it back, that if you can capture it, it's a nice way. But honestly, I believe in inexpensive stuff, and I like to look at things. You can do this with a phone. You can do it with a very inexpensive high definition video camera that's mounted on top of it. And you can then play that back and just manually record it, but see the performance of off-task fixations, how many were done, and how much time were they off. And then you can repeat it. So it's a very inexpensive. And that's what I did in the early days before I had made use of the Visograph. But this is another way, but the camera and so forth. A lot of the programs are out there. I'd like to be able to see what the person's doing with their eyes, okay? I think it's very important. And we've lost that eye contact. We've lost that ability to walk into an exam room and, the kid's on their phone, the parents are on the phone. You say, oh, we're going to stop. And the father will say, well, just a minute, I got to finish this text. And I'm done. Do I miss that? No. I go, could you please look up? I'm trying to do something with you now. So that's what we've come to in our society, but we can still work with it. So here are off-task fixations and on-task. Very simple. And if you start to gather this, I do a continuous performance tracking for a minimum of 3 minutes, sometimes up to 5 minutes. And you say, oh, I don't have the time in my practice to do it. I said, yes, you do. You can do this. It's going to give you a lot of information about the kid, and you want to see those things. And it also depends on who's in the room, who's the distractors, because those are things that will come into place. When I have the parent yelling, okay, now you listen to the doctor and do exactly what he says. Okay, mom, could you leave the room just about 3-4 minutes? I'd like to see what it is, and I'll show you what we get. Oh, okay, because that's a characteristic of other personal interactions that also affects a patient and a parent. Okay, so the assessment of a continuous performance test, there are quantified ones out there. You can look them up, you can buy them. They're not that expensive. And what they consist of, and I use this, like I said earlier, and what they do is you have them look for an AX. This is a classic one. And every time they saw an AX, they had to press a key. So it counted the number of times that they saw the specific target, and it can go for 5 to 10 minutes. And this is easy to do. I've made my own PowerPoint, and I can control the length of time it's shown on the screen, and I matched it consistently with it. So I didn't have the money, or did I wanted to control it and modify it any way I can. So if some of you would like help with that and have these little programs, they're very easy to make. And then I did it with the Visograph. So I could see, are they staying on the target? How well are they staying on this target? And I think these were critical pieces of information that I can now gather. So here's what I would get. Here's someone observing on the screen, and she's being videoed. That was my Visograph initially. And she had to watch at least 300 presentations on here to be able to do this. And I'm watching how well, and she maintained on-task fixations and the eyes, and her correct response rate was up at 95% of pressing the key whenever she saw an AX. So if you don't have a key, I just used a little counter that worked very well, a clicker counter. And every time there was a fixation off, I clicked it. So I was able to count the number. So we don't have to make expensive things in an office. And it's also a great way you can monitor anytime. Now, here's what it looked like when you took the visograph. Yeah, basically a straight line. That's what I was in time in seconds. And she was on that task. And I was able to measure a continuous performance on a sustained visual attention test. Hard data, pre and post treatment, and pre for diagnostic purposes. Here's the same kid and just videotaping it and using a counter. Moving around. This is my granddaughter when she was younger. It was the only one I didn't get into HIPAA violations. But she had some difficulties doing this, and we can clearly see that. Now, you take a video of this, you can count them and see them and show the parents what's going on. And I simply did this above a laptop.
Hope that you're doing well. And if you want to get on the schedule with.
So it's not that I'm old school. I try to find things that I can show parents, show therapists, show other docs. Here's what's going on and what we're going to be doing for the treatment. Now here's her on using the visograph.
Interested in getting back into the office to get an adjustment.
And I'm sure you're not surprised. And then I'll relate this to the symptom questionnaire. I'm going to relate it to the DEM and the other observations I had in pursuits and tracking and other things that the teacher or the parent would be reporting. So here's a simple comparison. Looking for off-task fixations and off-looking time, which is a very good method of probing continuous performance of visual attention before I even start. Because if I have this kind of pattern, my chances are, and what I said earlier, I'm going to have a real concern about the validity of all my other findings. My findings for convergence near point or near point of convergence, accommodative skills, other kinds of skills during the thing, because they can be easily distracted or I know they can't sustain the attention. Okay, I'm going to stop at this point and let you take we're going to do a 10-minute break so you can get up, move around, and we're going to come out and move up to this. Before you go, let me just show you what happens. We have all kinds of dyslexic. This is a great shot of the president reading with a kid, and he's holding his book upside down and trying to read it. So they come in all categories, but we'll explore this when we come back. Okay, 10 minutes, folks. I'll be back.
Dr. Richman, before you go, we
Yes.
just have one question early on.
Yes.
And Dr. Vandervoort wanted to know, when we were talking about attention, she wanted to know, wouldn't the person's short-term memory also play a role? If the person looked somewhere and then can't remember what they saw, then they would have to go back and look again. So I guess we wanted to just discuss like attention and how memory.
I think it's a great question, and I think that they're heavily related. If I find a continuous performance task and the off-task time, there's a very good chance the retaining of short-term memory is also going to be impaired, and I've seen that in numerous studies where the eye movements are off. So short-term memory is again something I just caution in looking at in isolation. I think that would be my simplest answer. I want to look at the visual attention and the sustaining skills first before I look at, because visual memory is going to be a effective visual processing retainment. And if I have impairment attention, then it's going to interfere with that as well.
Okay, beautiful. Thank you. That was the only question that we had come in.
Okay. Okay, we'll be back in 8 minutes.
Okay, and during this break, everyone, you do not need to log out and back in. We're in the same space. We're gonna run a quick video from one of our sponsors, and we're also gonna do our first Burnell raffle drawing. So let's get that loaded up for us. All right, how does that look, Mikey? Good? Here we go.
NeuroLens has been fantastic for our practice because it's letting us be not just the eye doctor, but one of their overall doctors that helps them not just see better, but live better. After wearing my NeuroLenses, I noticed that every day it just kind of seems to get better. I'm not stressed, I'm not tired, I'm able to work better, I'm doing better. Yes, I'm definitely happier.
Before NeuroLens, I was getting some severe headaches. And so I was using glasses for some time and then stopped wearing them for a time because I thought maybe it would help with my headaches. But then the NeuroLens came along and that changed my life. I think NeuroLens is a great addition to the optical industry because the contour prism is just something you can't find anywhere. You know, I remember years ago having patients come in and knowing that they were having problems and it was because they were convergence insufficient. But when you can give them a NeuroLens, it's simple.
I feel like I'm more productive throughout the entire day, not only at work, but at home because I don't have those same symptoms. I don't have the neck strain. I don't have the fatigue in the eyes. My eyes aren't red, you know, so it's changed my life in that way.
It's so rewarding to be able to help people in a way that I haven't been able to help them in 30 years of practice. So it's definitely the most rewarding thing that I have done.
If you're in a situation where you're getting headaches every single day, you don't want to take this medicine every single day. So now I don't even have to think about that.
I'm running 5 and 6 miles 5 times a week and going to the gym 3 days a week because I feel like getting up at 5 a.m. and living. So, yeah.
I'm just kind of checking in to see how you're doing.
Okay, now we'll shift right over to our wheel here and we'll spin for our first winner.
Feel free to give us a call. We'd love to get you on the schedule and see you in the office again. If you're interested in getting in today for a chiropractic testing, we have
Doug Steffi.
15 slot available.
All right. And your information will be sent directly on to Burnell, so no need to do anything. Joe will be in touch with you directly. All right. We still have a couple more minutes before Dr. Richman comes back on here, gives his voice a rest. Go ahead and get your water or whatever you need to do, and we'll be back in just a moment.
They're doing well. Otherwise, I hope you have a good rest of your day, and we hope to see you soon. Thanks. Bye.
Pensacola.
You're talking to everybody.
Did a word though, one word. Austin, that's the second word. Fort Lauderdale. Hi everyone.
Channeling our warm vibes.
Yes, it's a lot of snow out there this morning here.
Yeah?
It's ridiculous.
Whoa. We have not gotten any. We didn't get as cold as you all. We got the rain from the hurricane, but then not the cold front. But wow.
It's my front yard.
Wow. That's a legit first snow.
It didn't stick to the street in the driveway.
Pre-Thanksgiving snow.
Yes, I'm really excited.
Hi, Linda.
I can tell.
We'll talk later.
Okay. I'm just giving you a quick call because Sandy and I actually were just talking about you and how we haven't seen you in a while. I'm giving you a call to check in and see if you're doing all right. How you're feeling, if you have any discomfort or whatnot. We miss you over here in campus. If you want to get scheduled with us, we'd love to see you again sometime soon. We have a few availabilities today, even if you were interested in those. Today we have a 3:45 appointment available and a 4:15 appointment available. If you want to get on the schedule with us, go ahead and give the SLO office a call. They'll go ahead and get you on the schedule of your assistants. That number is going to be 805-543-8688, and then it's 805-543-8688. We miss you. We hope that you and Bill are doing well. Otherwise, I hope that you guys are having a really nice start to your new year. And I hope you have a nice rest of your day. Okay, thanks, Linda. Bye. Hi. Rylan? Yes. It's nice to see you again, because we've met before. Yeah. Pearson. Is your name? It's my name. Okay, perfect. I didn't know if you were asking for my last name. It's Lindahl, right? Yes. Yes, yeah. No, I'm Pearson. Thank you. Yeah. It's not spelled a lot of people assume it's spelled like the last name, P-E-A. It's spelled P-I-E. Okay. Yeah, it was named after like a street in Arizona. It is pretty cool. I like it personally. So they've got Rylands. Yeah, I've liked all the Rylands today. But actually, I've never met a Ryland before. I've met a Ryland. Oh yeah. R-Y-L-A-N-D. That's what I was trying to get out of a Ryland. Oh, the community is the same thing. I like it. How are you doing? Doing well? Yeah, I don't feel like, excuse me, I get the interview calls to patients here. See if people want to get on the schedule. But otherwise, yeah, I mean, Doc knows you're here and he'll be probably in the next 3 to 5 minutes. Slow Wellness Center, how are you doing? I'm doing well. I'm actually just giving you a call to check in and see kind of how you're doing. Sandy and I were talking about how we haven't seen you in the office in a while. We're just hoping you're doing okay. And wondering if you want to get on this schedule again.
Jack, can you hear me?
Yes, I'm here.
Oh, hi. This is Phyllis Liu. Could you send me some articles about schizophrenia and bipolar?
And eye movements?
Yeah.
Yeah, I'm preparing it for a couple of police officers right now.
Oh, okay, good.
Send me an email. You have my email.
Yeah, and I had a couple questions. Do you ever use audio with the visual to help the kids increase their comprehension?
Yes.
While reading, yeah, because they can always listen to a higher level than they can read. Also helps with improved vocabulary and things like that.
Yes, when I get into the treatment, I'll talk about fluency.
Okay.
That's what you're asking about.
Yeah, and when you do, sometimes when I do therapy on kids, because the pursuits are so bad, I start with saccades first. They seem to be easier. I don't know what other people do that.
I'll give you a couple ideas when we get into the therapy, okay?
Okay.
Am I supposed to start soon?
I don't know.
Yeah, I was just gonna interrupt and let you know it's start time.
Okay. So I have my screen back?
You gotta share it again.
Okay.
At the bottom, the green share screen button.
That's it?
And then select what you want to share.
Right there.
Ta-da! There you go.
Am I up? Yeah. Here we are.
Yeah, take it away.
Okay. Now, sometimes we look for things that are out of balance, and some of the reasons that we see this out of balance with the systems, and I mentioned it before, but it made sense to me. If that peripheral search is disrupted in any way, it'll lead to a loss of automatic processing of the information. Hence, disruption there will increase the time and we get loss of automaticity. And a good example, we have a number of different things. And then the what is the system, if the peripheral one is messed up, then it'll reduce the resources that can be used to process the next peripheral word. So that this is why I look at the role of attention to see if they can stay on it. And I want to make sure we're getting smooth patterns. And I think all of you are aware, I have seen that where you'll see the loss of automaticity in someone who's a presbyope, and you put the lenses on and you get improved function. So we'll come back to that. So with this, let me get this. Move this over. Okay. Now, eye movements and the automaticity, I break this down into three. I'm trying to blend the three concepts. If there's any breakdown, the ability to sustain and for visual attention, it's going to affect the processing of information automatically. And if that becomes the problem, then the accuracy and efficiency in the ocular motor testing that you see, the accommodative and the binocular functions are also going to be compromised. And you're not going to be sure, in my mind, what I saw in the early days is where's the problem. So I tended to focus on the visual attention component. So automatic processes and reading then are compromised. Let's take a look now at automaticity. And I think most of you are familiar with it, and I'll get into this very quickly. It's an elimination of conscious awareness of attention in the processing. And it refers to the ability to have minimum attention. You see this with cab drivers, other people who can do things very quickly. Experienced practitioners can do things very quickly when they're doing an exam. You don't have to think about them. And you're going to have accuracy, and it's going to require less demand. And what's interesting is where I've talked recently over the past few years of practitioners who have gotten either the flu or COVID, and they're taking medication. Their cognitive abilities, their ability for capacity was greatly reduced. They were taking a lot longer and doing their exams. Talked to other docs, the same thing. And the whole thing is I explained to them what's happening, the meds you're taking, the other things that are going on, you really reduce the primary entry point, and that's your attention skills, which then affects your automatic skills. And you just want to go to sleep, or you're just very confused, and it's not an unusual thing that takes place. I'm dealing with that with older senior citizens in the same way. And I'm convincing them it's okay to take a nap, and it allows that blood levels and other things to recuperate. And we get those changes in attention, and their other skills come up. Okay. So controlled versus automatic. Here's your two things between and automaticity. They're slow, less efficient. Now, controlled processes are very important because they have to be accurate before you move on to automatic. I have to stress that. And I find it's very important. We will often stay very carefully in the control where you're putting a lot of attention into doing that task. You have smaller central processing, but you'll get it done. The more you do that, the more automatic it'll become. So this trade-off will be an important thing. I've lived through this for a year following my head injury, and I'm aware of that. So these are things I think are important. And one of the aspects is practice with repetition and feedback. Feedback is so important for many of these skills. I don't think, and I've seen this many times, we don't go further in our treatment. I saw this in the clinic, that I wanted the kids and the adults, if we're doing accommodative work, if we're doing fusion work with loose prisms or whatever we're doing, I wanted, or recoveries in that matter, I want them to get to the point of getting it, excuse me, getting them to a point, I apologize, getting them to a level where it's really good control and then picking it up. So automaticity in reading and reading fluency is something that I have to discuss. And I find that with a lot of the occupational therapists, the others, is getting the individual back to reading smoothly, or the kids in the classroom and reading it. And this concept came out years ago. And fluent reader is one whose decoding processes are automatic, requiring no conscious attention. Wow. When I read that many years ago, I said, that's the key words that I'm dealing with: automatic, automaticity, and there's no conscious attention, because the attention systems are already working and they can allocate it to something else. So this became an important thing when they discussed the early phases of developing reading fluency. And that's essential for comprehension and the meaning of text, is to be automatic with it. So why is it important? Well, they're able to focus their attention on understanding text, and fluency will lead to that. Non-fluent readers are still at a control level, and they're still calling out word calling or just very brief things, and they have less attention to focus on, do you understand what you just read? And they go, no. And that was a very common thing, because they didn't have the ability of the language component. So fluent reading requires automaticity. It is instant, it's accurate recognition of letters and words, and what those things mean is also important. It increases comprehension as readers focus on meaning and not just decoding. I could learn how to read German very, very quickly, but I had no clue what I was reading, because I had not matched it to the comprehension component, which was essential. Okay. Now, automaticity and distractors is a very important component in the therapy and in the evaluation. We can assess someone's attention skills and automaticity, but I also want to be able to deal with it in the setting of where the child or the person's going back to, be it a driving task, be it a classroom task, and sometimes with some of the law students was going back into a courtroom, where now things had to be more automatic, where they were able to do it in a less distracting and stressful situation. So, and that's caused by many times the lack of ability to pay attention, and this is what I've gotten back from many of the patients. Lack of interest in the object of attention, and these are distractors, and the great intensity or attractive something other than the object of attention. That's unfortunately where the rubbernecking of crashes, some loud noises on the outside, whatever may be taking place. a good-looking man, a beautiful woman walking by, and then it greatly distracts what they, and they say, could you repeat what you just said? So it affects the memory, obviously, because the attention was shifted off of it. And distractions come from external sources and others. In school, public address announcements are very disruptive from what the teachers and the kids have told me. Bells, hallway noise, classroom noise, and it's very, very disruptive. The cell phones and the have also been one of the bigger challenges. At home, music, sometimes music helps you to concentrate because it's not a distractor. TV or video sound in another room. Balance board and walking, I find, is a very effective way to add a distractor of all the techniques that are very valuable because they involve the motor planning and the cerebellum, which also, the cerebellum is very actively involved in automaticity and attention functions. And it's even been proposed as a cerebellar hypothesis for dyslexia. So balance board and mixing the two, and I'll mention this as we look at some of the treatment techniques. Tracking and auditory interaction is also, verbal is very important, that I think supports staying on track. And you see that many people will say out loud what they're trying to do, and I think these are important things. So how do I assess this in my practice, and what did I do? Well, there's a number of ways you can do these. One is reading rate, and you can also deal this with rapid automatic tests. These are available. You can buy some, but it's rapid automatic number calling or figure calling is a fundamental indicator how the brain can put together visual and speaking processes. And that's something that was discovered a good number of years ago. And why is this automatic visual verbal calling so critical to reading speed? Well, what we found is rapid naming really probes the matching of what they see in the periphery, then the next fixation with the eye movement, if it's done correctly, and helps identify that they know that word on an automatic level. And this is called fluency. And why this is important, it seems to be a fairly good predictor of kids who will have later learning and reading problems. It's also a way to measure and guide their progress in that. So rapid naming or RAN skills and tests that are visual verbal is the majority that of these kids, if they're reading disabled, will have a deficit in rapid naming, and it could be rapid number calling, it could be rapid word calling. So let's you'll see a number of these. Let me skip through this. And delay in RAN can result in early reading failure. So digit naming speed relates to word recognition accuracy, word comprehension. And this is where the DEM evolved to get some of these clues. One of the tests that's used quite a bit is called the RAN, Rapid Automatic Number and Symbol. A majority of these children with these disabilities will exhibit difficulties in naming speed who have reading disabilities. And this continues to be used out there, and it gives quite a bit of information. And here's an example of it. They'll have to call out very rapidly objects, and they're timed, and they're scanning from left to right on these sheets and these test sheets. Others deal with calling out colors, black, red, yellow, green, and they go across as fast as they can because that is a visual to a verbal retrieval skill. Here's numbers, and numbers seem to have a much greater loading as it relates to reading and fluency. And this was the basis for why I incorporated it with the developmental eye movement test. And here's where they'll have a combination of colors, letters, and numbers which increases it because these act as distractors as well. So these have all been standardized. It's called the random automatic number calling test, and you can buy these. They take a bit of time, but I think they're quite effective. And Dr. Lawden and I did a study back in 1997, and we looked at visual verbal automaticity in first graders because they wanted to see, this is in the early phases of the DEM, and we found as the time increased to complete the test in the horizontal number array, so did the time in the vertical test increase accordingly. So the vertical test, from what I showed you and when we did the original standardization of it, was related to rapid serial visual presentation, that you did not have that peripheral search interference in any way to the level as you did when you're just reading from left to right and going across. And the common function was this, the automaticity of number calling. And we did that 25 years ago. Children in kindergarten, we reported this at the American Academy of Optometry meeting. And what we found is that children who performed in kindergarten, first grade it was then the New York State Optometric Association KD test, may be performing unsatisfactory due to a delay in automaticity and not ocular motor function. And that was an important point we wanted to make then. I did other studies later that even made it even more clear that the test, such as the KD at the time, was not measuring ocular motor function, but in most cases, automaticity dysfunction. And that's what led me to even more use with the DEM test. In 2001, that's 21 years ago, Andrea Lowther, who was an excellent special education teacher, and she used the test as a predictor of word recognition. And she found that the DEM vertical test used as an alternative for the rapid automatic naming test may be used as part of a comprehensive assessment of word recognition problems. And this was published, interestingly, if you notice, in the Journal of Optometric Vision Development. So that was there, sitting there 21 years ago, as use of this as a clue to automaticity. And then you can then relate this to your visual attention testing that we've already talked about. Does the RAN relate to eye movement control? And I wanted to find out if there was. So I did some more digging, and what I found is that there was. And functional MRIs used to evaluate it found that not rapid number naming tasks activation from functional MRIs was found in the neural areas associated with eye movement control and attention, as well as a network of structures previously implicated that I showed you. But they found this strong link between activation of attention control that was necessary during these tasks. So this gives us even more support that the use of such a test for automaticity also relates to what are the systems involved in having it function, and specifically eye movement control and attention. And so this weaves back to my whole premise of the role of attention, role of eye movements, role of automaticity as being critically linked together. So how do I do my eye movement assessment? When we talked about this, cover tests, we test vision mostly straight ahead in most cases, and in 8 seconds. And they say, oh yeah, our eye movements are good and it doesn't affect reading. Well, we know that doesn't work, but we still continue to teach that. And I talked about the visual and the position maintenance. And I want to stress again, this holding a target up there of limited low attention is a single, very sensitive measure of the status of the ocular motor system. And I've looked at that. In other words, the absence of movement and the ability to just hold it is a very sensitive measure of the concept of attention and holding it on that target. And we've seen this in hundreds and hundreds of cases of assessment in the hospitals, in the clinic, and also within law enforcement when we do various tests at looking for impaired eye movements. So I mentioned this before, and I want to stress this. So attentional dysfunction and during this assessment is really the problem that I think is there rather than an ocular motor control. Ocular motor control is where we're seeing this attentional dysfunction. I'll stress this again. The ocular motor behaviors we see are giving us definite information of attentional dysfunctions, and that's what we need to be addressing and looking and how it affects the individual. Okay. W.C. Maples has an ocular motor test. It can give you some good quantified data. And then we have the electronic methods and the visograph and the readalizer. And, you know, we get this information from these pieces, as we showed you before, that it's all going to take longer to read a line if there's something breaking down, either in the automaticity or the fluency of the words and understanding them, the attention components that are taking place. And I've tried this with numerous people where I put loud noise on and having people walking in and out of the room. And I find that the kids or the adults were able to do this. When I had them read it to themselves again and measure the visograph, it did not have any significant impact. They're able to concentrate and mobilize that attention, where the ones where those external distractors were there, I saw the performance really fall apart. And I think these are tools that we have, and we can use them by increasing them. And several docs have asked me about adding the use of distractors. I think it's a very important differential test. It's similar to a stress test that you have for an electrocardiogram or anything else. You want to see what happens when you put a sustained stress on the system. How does it maintain itself? And this is a way by adding the distractors that can then see it. If you see it in the beginning, you have your answer. But if you don't see it, now you want to see what happens with distractors. And I think that's important.
When I was growing up, it was taught.
In these, we looked at the KD test in 1976 and the impact of number naming on a clinical test of eye movement function. And what we found is that we wanted to investigate whether a subjective test of lateral eye movements at the time using a visual verbal response format. This is not in any way a condemnation or criticism of the test. This is what has evolved. It was part of what I needed to understand why I needed to redesign an eye movement test with rapid number calling. And what we found is that eye movement skills measured with subjective visual verbal formats as described, which is the KD, are deficits in automaticity of number knowledge and not ocular motor dysfunctions in some children, and I felt in many children. So that was what we needed to do, and we needed to develop the rapid naming much more effectively. So do we see developmental changes in eye movements during the school years? Yes. Okay. And changes in the DEM and the eye movement patterns are very similar, which I found very interesting as I continued my work with it. Here is fixations per 100 words, and you see the graph goes down and the efficiency improves. Okay. Regressions per 100 word drops significantly as each, so you're getting more automatic function in the eye movements. Average duration of fixation improves up to about 9th grade, and then will increase and become more efficient later on and levels off. And when we look at the DEM, the mean vertical time followed a very similar slope as a function of age. So did the horizontal time.
Well, they had
and when we looked at the fixations per 100 words, so the DEM gave us a real good indirect observation, not a direct, but an indirect observation that is very similar to what we can capture with actual electronic products such as a visograph and other ocular tracking devices using infrared or similar products. So I think this was a point I wanted to stress, even with the mean ratio scores that kind of dropped significantly and became much more efficient when you got to age 8 and just levels off by the time you're into middle school. So it gives us a clue, an indirect measure that automaticity was working fine, and the ratio could reflect this. And the increased automaticity and efficiency as a function of age was very clearly there. We saw the great slope is very steep from 1st to 4th grade, 4th to 8th grade, the slope gets flatter. And this was true in the Visograph and in the DEM, which gave me a lot more confidence in that at least I'm measuring some similar functions and the automaticity. I'm going to revisit this briefly. Developed it over 20 years ago. And I did an update of the manual in 2009. And the people says, does it actually measure eye movements? And the answer is no. It's a reliable and valid measure of an indirect ocular performance in a simulated reading task. Does it measure eye movements? No, it doesn't measure fixation, duration, regressions. It doesn't measure any of these things because it's only a visual verbal test. So that the criticisms of it are still aimed at it, but to understand it's not intended to be a direct eye movement measuring test as a Visograph or right eye or something that is actually capturing very specific fixations, 4 fixations per second. We're not getting that, but it gives us an indirect measure and the role of automaticity and rapid number calling. And that becomes a very helpful way of differentiating what's going on with a kid and helping give guidance pre and post treatment. Can attention affect the responses in the DEM test? Yes, there's no question. All kinds of variations, environmental, noisy room, poor lighting can adversely affect influence on a child's performance. Yes. So these are all outlined in the new update that I did in 2009, but I put them in there because they do have that effect. Who can administer the test and examiner characteristics? These are very important. The people who administer the test need to understand how to control the environment, how to administer the test correctly. And this especially includes many optometry students, which I've seen the most bizarre methods of administration of the test. And who is appropriate to have the test administered. So the question is, how do we, when we get analysis, if a vertical score is low, we're going to look at further testing on attention tests and RAND tests because it's very likely it's related there. If the vertical score improves, then we'll retest it later. If we find that the horizontal score is low, we still want to retest and look at the attention test components. And I think that's important to consider. And what I'll often do with that is I'm going to repeat the test with tactile support. I'm going to let them use their finger. I'm going to let it use a guide. And in many cases where they redo it in that manner on the horizontal component, I get a significant improvement. That tells me that attention could be allocated. They could stay on it. And in fact, in a good number of those cases, the vertical score rapid naming was good, but on the horizontal, it was not. So it gives me a much better eye. I'll either repeat that, like I said, I'll do a Visograph to get more information, but that's clear indication for the ocular motor therapy that we would plan in the office. So it helps me sort out by looking at this flow chart. And that's why I put that in there for you to use as a quick reference. And I do that, and I've been doing that for quite a few years. And that's what I finally did in the rewrite of it. We use percentile scores because that's very common. And I think that's important relating to school data. And you're going to use it as a screening test versus a clinical diagnostic test. Screening test, there's a lot of reading teachers, nurses, occupational therapists that use it as a screening test. There you can change the pass-fail rate, having a lower sensitivity. So you'd have maybe 1 standard deviation from the mean, where if you use it clinically, you're going to have a more sensitive one, maybe a half a standard deviation away from the mean. And that's all discussed. But I wanted to bring out the more and more people are using it as a screening test So if you have people you're working with and you're going to give it to them to use as a screening, that's well within the realm of the DEM, because honestly, the first time when we designed the test, Dr. Garcia, myself, and others, we wanted this as a screening test. It's taken on a whole new life of its own over the years. So, can accommodate binocular dysfunction affect eye movements? Yes. I mentioned this earlier, where we have anything that disturbs or makes a blur, binocular vision, accommodative. So here someone reads clearly. What happens if now presbyopia comes in and it disrupts the chunking of the information? You put on the lenses, the chunking is much more accurate, goes back to what it was, and we see an important. So it's just stressing why I need to sort out the attention component in addition to prescribing the plus lenses or other lenses, because you may get both things improved. Absolutely, you can do both without a question, because something is disrupting the smooth chunking of information. And it could be visual attention functions, it could be accommodative and convergence functions. And there's a good deal been written regarding convergence functions and its automaticity. And that's why they need to be raised to an automatic level, time-based. So I've just brought those things up. What I want to do is look at, in the remaining time, how I've taken all of this and what I've been stressing and how I can reduce time and maintaining efficiency. One of the things is automaticity and distractors that I mentioned. And I want to make sure that when I'm working with somebody, that whatever tasks I have to get them really good on the controlled process, be it with visual motor support, be it with verbal support, so that it's time independent. Once you get to that controlled process level, then you can start to increase the time demand on it. And that has less effort and it's faster. And that's what we're looking for, automaticity. And that, to a large degree, is what I've seen over when all the data on the DEM and all the data on the eye movement data is, as each year goes on, you become more efficient and it levels off. And if anything disrupts that automaticity, then it's going to fall down. And you go back to controlled processes and the 6 components of what is visual attention. And that's the cognitive load, the effort load. All these things will affect the attention. So once a certain level of successful automaticity is reached, I now use divided attention with distractors. And they can be anything from music, TV, balance board. It's absolutely fascinating where you can get someone to do very well with a Marsden ball, batting, put them on a balance board, and the automaticity in that skill just falls apart, versus the ones that are able now to get it so that it's more automatic, because it's really forcing attention on the visual components. Okay, so divided attention comes in later, and I find that's an important thing. And I also look at it where it's not transferring into the classroom or the job, is something is putting a better load than what I had addressed for in the clinical therapeutic program. So feedback is important. And one of the methods that I like to look at it, feedback, is the patient and the therapist. There are people who are not good at doing these. They bring their own personal style to doing this. And I think it's a challenge that someone who's working in visual attention automaticity and improving it, they need to understand how that's affecting attention and not just some test results, okay? So I use modeling. If I'm gonna work with a kid and I'm gonna say, look, here's how I do this. I want you, and I'll do the swinging ball. I'll go on the balance board. I'll do any of the tasks first, okay? And sometimes I'll do it bad, and I'll say to the child, did I do this good or bad? No, you didn't. You did it worse than me. I go, good. Now there's an awareness that's there. So, and I have them stop. I look. I tell them, what are you doing right now? Stop, look, and verbalize. And modeling is one where they watch you do it correctly or incorrectly. Stop, look, verbalize has been very helpful because I want to hear if they're aware of what's going on. And then I'll show them other strategies of doing a task. And we talk about different ones. And if they become aware there's another way to do it, that means that they're attending to it and they're looking. So that will increase on-task time. And of course, you have biofeedback techniques that you can use where there's buzzers and sounds. And let's look at some. One of the things I use are laser pointers and flashlights of keeping that on a moving target or locating things rapidly. And there's also ones that respond very quickly to a pen light or to a laser pointer and buzz as quickly as you can. So these devices, and anything that is time demand makes a difference. The perceptor motor talking pens I've used for years, they're still available, and it uses a method of feedback for tracing and gives not just the tracing and the motor skill, but it keeps them on task. So there's other things that they can do with this, not just in the tracing book. And if the buzzer goes off, it goes off. I've done this with Down syndrome kids, autism spectrum kids, and you can see where you get them into it easily, and then you increase the load. I'll make simple things of loops, okay? They have to keep the loop around the light. Can they do that? And I'm watching their eyes, and I'll say, are you on it now? And I go, no, you're not. And they'll look back, and I keep watching, and sometimes you videotape them. And this I've done with the traumatic brain injuries at the hospital. And I've gotten very good results because I'm giving them feedback to where they're looking. And this is a very cheap, inexpensive way to do that. And for the tracking, because it involves the motor system. So I like to keep simple. I like to be able to give things they can do at home. The ball and the stick, tremendous tool. Lots and lots and lots of things you can do with it. I've done it with multiple different kinds of balls. Steel balls, where it swings behind their head. And I said, are you watching it? Yes. And it hits them in the back of the head. Now they got feedback. And literally within 20 minutes, they're now moving and aware of the periphery. Put them on a balance board. And there's all different kinds of balance boards today. I use a BESS sponge platform, which is used for balance control. And there's other ones that you can get them doing. And the other time is as they start to get better, I will have my hand on their belt and I will push them in different directions to see if they can maintain the balance and keep their target watching on the ball. This is what a lot of PT has done and therapists I've worked with, and we find it really goes up to the next levels as distractors. The kinestoscopic skills are all time-based. These are also very helpful for improving on-task time, okay? Speed reading software, there's tons of them out there that are very effective. So if we're going to be doing these activities, there's quite a few that are out there. Computer-aided vision therapy, and we have HCS has some very good ones. I'll use this with the tracings, but I also do the modeling. To improve the intention. I will do it with them, and I do it wrong, so that I want them to tell me it's wrong. And then if you're saying to them the teacher is going to do it wrong, it's an amazing the mobilization of attention to while I'm doing it. No, you're off now. You're off now. Good. Okay, let's try it again, and then we go back and forth. So modeling is an old technique that has worked very well with this. Visual tracking workbooks. A lot of variations, but I want to find ways to keep them on the target. Laser pointers from beneath can be very helpful. Pen lights on top can be very helpful to see how fast they do it. Okay, and then you add distractors or more lines in it. So it's taking the materials we have, but I'm looking at. Parquetry tag can be a very effective way because I want to see if I know there's an attention problem, we can modify these with that because there's a time component. You keep increasing the time. I first go where there's no time demand, and then you add the time demand. So just giving you some ideas. Metronome is extremely valuable to integrate the changes in attentional maps because you're integrating the cerebellar controls. And this also increases attention because they have to listen to the sound of the metronome at the same time doing the visual task and staying on it. And it's amazing how quickly these skills come up, and then you can transfer them to others. Sight word rock, these cards are still, I think, available using accommodative, but they also are dealing with sight words, which helps for fluency components. So one of the techniques that I've used is, and I find very helpful, is called neurological impress. And this is based on perceptual chunking and patterning of reading behavior. And the process, and here's the correct reference. The one I gave you in the handout was not correct. But you can look at a video. If you go to YouTube and just put in neurological impress, you can get some nice 3-4 minute videos to show you how to do it. And the other one that's on here now is correct. This was where you read simultaneously with the kid. You pace the kid, okay? And the kid has to keep, the child or the adult has to keep up with you, okay? And simultaneously from a book or any material. And you can see where it starts to break down. You're going too fast or too slow. So you start at a very slow level to see that he knows all the words, part of the fluency. Now you start to do it faster. And you can also change the material in which he's working. But in many cases, I try to work with material that the individual, the adult or the child has to work with on a daily basis, because that's going to be the environment. Even though I may have changed and looked at that there's attention problems, and we can modify the print if necessary. Computer-based therapy techniques, there's lots of them out there, and I think they're underutilized. But when we talk about the ones, Vision Builder is excellent. It's still available. It uses the moving window component. I think it has tons of values because they can't reread with that. That's when they can't do regressions with that. So by doing that at a very slow speed and you select the text, you're going to improve the fluency, the automaticity, and the moving window is going to help gain the attention. The other thing is you can put any targets into that moving window that they have to look for and pay attention to. And I'll spend a whole bunch of time initially if I have some kids that can't maintain attention onto a target. And the other ones are quite good. Peripheral vision is quite good. These are the two that I've used the most to get the improvement in the attention functions that I'm after and the automaticity. This is a dynamic reader. It's still available. And you can design tons of things for reading with that. And that is available. And I'm not marking this for anybody. I'm just telling you what's out there. And what I've found is a lot of times people are not aware what's out there and start to play with it and looking at how you can now manipulate this to improve automaticity, improve on-task time, which is critical because you can manipulate the targets in any way you want. Perceptual visual tracking program is out there, and understanding tracking and ocular tracking and fixation. I've tried to give you a different view toward it in terms of attention function. And I think that is an important component. This one, it has so many different things in it. Some people say it's overbearing, but if you spend some time, I think it's very good. The moving line, the moving box, the saccadic tracking. All you can do in all of these is manipulate them. So you get the time components on them and build up to control level and then to automaticity level. So combining that with the neurological impress method of improving the kids' sight words. I've seen dramatic differences in many of the kids I worked in the inner city in 3 weeks. And the teacher, you know, we had throwdown challenges. He won't learn it. It'll take a long time. I said, no, we're going to practice it. And they would come into the clinic 2-3 times a week. And we did this, gave them not a lot of tasks. We worked on these attention building tasks and the automaticity tasks. Once they started to be able to do them better, the teacher noticed it. And the teacher now is going to interact with the kid much more positively. And that's something we don't talk much about, okay? And the mother and the parents are going to interact more. So the kid starts to feel better about them. That's the support and the psychological components in rehabilitation, which I think are important. So I mentioned the dynamic reader. I like that a lot. And you need to sit down, but if you take it from the frame of reference, we have moving text in dynamic reading, that can be used quite effectively for visual attention function. And also whole line dynamic reading, again, all time-based. When this came out a number of years ago, I said, this has tremendous value if you take a different model to using it and not just ocular tracking. And as I said, I think that is the hallmark. This is no longer available, this particular one by Gary Vogel. And it had a lot of good things. So let me put this together. I would offer these practical approaches for patients with attention, oculomotor, accommodative, and vertical dysfunctions. One, if there's evidence from the history and performance at home that you do have an attention or automaticity problem, you really need to address and focus the therapy toward that, especially on the attention in the beginning. Also be aware that these dysfunctions may be compromising your accommodative, other tests that you have, and Virgin's functions. So it's important to get a handle on, do I have these attention and sustained attentions and vigilance? And I showed you how I measure them in the office with simple ways. Takes a little longer time, but this will give you a direction of where you want to go and how quickly you want to go. Many times I had kids, they were spot on with this, and I go right to the other optometric skills for convergence insufficiency or intermittent exotropia or esotropia accordingly. But I knew that I can handle these things with them. The second is, if there isn't these deficiencies, I think that the therapy management should be focused on those in the beginning of visual attention and impulses. Many of these kids are impulsive, and you do this in the beginning phases of doing everything you can to get them to understand what it means to stay on the task for longer periods and giving them the feedback for it. And then you start to introduce more time demands for words, for letters, and the distractors. It's just rearranging things that we've done for many years. So the visual fixation maintenance activities, visual tracking and tracing, tachyscopic, physiological diplopia, string, are they aware of it? Can they hold it when they look back and forth between beads? Can you move it in different positions? But what I'm also doing is I would actually take video of them while they're doing it, and we'll play it back and show them, were you looking at where you were supposed to? No, I was off there. I was off. Good, let's go and back again. So I didn't do a lot, but I wanted to make sure they could stay on that task. And the third thing is, once those skills seem to improve, and there were deficits in the original clinical findings, I go back and retest them because I want to see, have they been normalized before I add in more accommodative invergence and stereo and refract. And I'm also going to look at what did it affect, or how did it affect my refraction, and what the lenses. You can see this with near point retinoscopy and multiple other ways. So with that, I gave you a reference list. If this is not enough for you, I can clearly give you many more, and I'll be glad to help some of you. And my goal today was essentially to give you a different approach, I think a very effective approach to looking at these patients that come in with learning problems, with neurological and potentially head injury issues and other diseases that are taking place, and working first at a real good control level, improving attending skills, giving them feedback for it, and then move on to make it even more automatic. And we've done this with driving training and the driving education for some of these people. And that model has worked quite well once I sort out the attention and the automatic and automaticity functions, all seen in, as I said before, through our eye movement analysis. Okay, folks, that's all. I think we have a good 20-minute break now. And Colleen, you can come in now if you're there.
Yep.
Okay, it's all yours for 20. Now they take a 20-minute break.
Yeah, we'll be back here at noon. But first of all, I just wanted to ask if anybody had any questions that they wanted to pose to Dr. Richman before we break. Oh, somebody has a hand raised. Vicky, you can unmute. There you go. Oh, we still don't get you. Your audio is not working there.
Who, me?
No, Dr. Vandervoort.
Okay.
How's that?
There we go.
Thank you. First of all, loved the content, and as usual, I just want to have a little thought that I, as a former elementary educator, have had. I've run into trouble with teachers. We get to end of therapy on Visograph. They are reading with silent reading, of course, reading above their grade level in terms of rate and comprehension. But yet the teachers are testing as required, at least in the Omaha Public Schools, and others around, with oral reading. And,
great point. Very good point.
Yeah, and I just try to tell the parents, you know, okay, what in life do you have to read fast with comprehension out loud? There's hardly anything. And so what do you say to that?
To the parent?
Yeah, to the parent and the teachers that are all worried about how fast and how fast a child can read out loud.
Okay, that's a great point. There's several ways. One, you could do what you just said to the parent, that this is not what you're going to do in the real world, reading out loud, because people are going to be looking at you strange. Okay. The other component, that there's been a whole bunch of comparisons between oral reading scores and silent reading scores, and there's a clear disparity. I agree with you that the silent reading scores is a different processing method. And I try to tell the teachers and even the occupational therapists I work with that it's a different process when you have to go from visual to verbal saying it versus reading it out loud, because what is important is the comprehension component. So I'd say to the teacher, what's the comprehension that were you able to find the comprehension on silent reading? And they go, no, I never did that. Well, see if you could check that, because the kid probably understands the text very well. But when they're trying to read it out loud, that's a whole different process, because when they're reading out loud, the verbalization is slowing them down. And some of the teachers said, wow, I didn't realize that. So all you can do is move them through it, even though they have the restraints of having to do oral testing versus silent testing. And sometimes you can actually, if that's a major issue with a particular teacher or parent, I've administered both tests to see the difference. And I don't want to say I want to train the kid to the test so that they do it, but there is a clear difference when you have to go visual to verbal versus visual to silent. Visual to silent is a much more effective way, and it's also a higher level of cortical processing of the words. So you can try that dialogue for what it's worth.
And especially when RAN is bad. And that's really where we, bump into it, because obviously their norms are for
Yes.
oral reading. And so if the child that has poor RAN is falling behind their norms, they keep saying, well, vision therapy hasn't done anything to fix this. And so I guess I'm pointing out that there are those that can't ever pass an oral reading test because of RAN. And I'm not certain it's important to work on RAN because in the real world.
No, I think it's a very fair point. What I have found is where I found the on the DEM where the RAN was down, okay? And I was able to retest that periodically, regularly through the therapy. And I started with, and before I'm done with it, I would find that those scores came up because that was sometimes an attention process or it's with the actual words. So to give you a little background, the original DEM was done with words when I first designed it, okay? And it became problematic because many of those kids were not familiar with those sight words and other ones were. I would look at continually monitoring the vertical scores with the DEM, and you can modify it any way you wish to incorporate that kind of practice for tachistoscopically presented the words and flashing them, and those scores will come up on the RAN if you train it to the test.
Okay, thank you very much.
Can you hear me?
Yes.
I once had an English professor came to me for visual therapy because he wanted to get rid of the inner voice that read to him when he was reading. So I think as a child, he did too much oral reading. So that's the way that he read. Now he had to hear this voice.
That's a little frightening, but you have to look at ways of shifting. That's not an intentional, that's a linguistic way he's processing the visual to verbal words. Thank you, Phyllis.